Welcome to the webinar, Strategies to Support Homeless and At-Risk Clients with Effectively Utilizing the Healthcare System. Thank you for joining us today. My name is Stacy Fox, and I'm with the Technical Assistance Collaborative. Before the webinar begins, I'd like to take a minute to review a few webinar logistics and tips. On the left side of your screen is the viewer panel, where you will see the presentation materials. On the right side of the screen is the control panel that includes a questions box. You may submit written questions throughout the webinar by using the questions box, and we will read them aloud for you. Today's speakers will each present for about 10 minutes. Following each individual presentation, there will be an opportunity, if time allows, to respond to questions. We will also have time for questions and answers after all the speakers have presented. Contact information will be provided at the close of the webinar, and the slides that will be presented today will be made available after the webinar on the HUD Exchange website. Today's webinar is being recorded and will also be made available on the HUD Exchange. Now I'd like to turn things over to Rula Swice, the Supervisory Program Advisor from the U.S. Department of Housing and Urban Development. Rula?
Thank you, Stacy. Again, my name is Rula Swice, and I'm a Supervisory Program Advisor at HUD's Office of the Assistant Secretary for Community Planning and Development. In this capacity, I administer the Housing and Healthcare Integration Technical Assistance Initiative, also known as H-Squared. The purpose of the H-Squared initiative is to primarily support HUD's homeless assistance grantees and grantees of the Housing Opportunities for Persons with AIDS programs to improve care coordination, linkages across housing and healthcare systems, and expand overall capacity to better serve people experiencing or at risk of homelessness. This webinar is third in a 6-part series included in the H-Squared initiative. The last webinar presented strategies for enrolling clients in healthcare insurance. This webinar will focus on keeping them engaged in the healthcare system and supporting program recipients with learning how to effectively utilize the healthcare system. Homeless assistance grantees funded by HUD are expected to not only rapidly rehouse individuals and families experiencing homelessness, but also facilitate access to and effective utilization of mainstream healthcare services. We know that individuals experiencing homelessness, especially chronic homelessness, overutilize acute healthcare facilities like emergency room departments. A disproportionate share of healthcare spending in the U.S. is used to provide care to a relatively small group of patients. The distribution of spending is even more uneven within Medicaid, the primary insurer for a large portion of the people HUD serves. One of CMS's 2013 informational bulletins cite that just 5% of Medicaid beneficiaries account for 54% of total Medicaid expenditures, and 1% account for 25% of total Medicaid expenditures. A growing body of research suggests that these individuals who suffer acute illness or trauma, have serious chronic conditions, and disproportionately experience homelessness are not receiving coordinated care, preventive care, or care in the most appropriate settings. They do, however, accumulate large numbers of emergency department visits and hospital admissions and experience tremendous suffering, which might have been prevented by relatively inexpensive early interventions and primary care. This emphasis on prevention, early intervention, and primary care represents the intersection between the housing and healthcare systems, and we are strongly encouraging HUD's homeless assistance grantees with supporting the clients in your care to shift away from acute care setting utilization, which has a tendency of being fragmented, and move toward this more coordinated model. This is going to require strong partnerships, a lot of education and training, and systems coordination with healthcare entities, many of whom are also participating in this webinar today. The information and resources made available through this webinar will support you in this endeavor. Today you will hear from 3 panelists who will provide you with very diverse perspectives on how to support homeless and at-risk clients with effectively utilizing the healthcare system. Our first panelist from the Centers for Medicare and Medicaid Services will present a toolkit developed to support this shift in approach, which HUD strongly endorses and supports. Our second panelist will provide you with the perspective from a managed care organization, or MCO. MCOs are contracted to deliver Medicaid program healthcare services with a special effort to reduce program costs, better manage utilization of health services, and most importantly, improve quality of care through more coordinated service delivery. If you are not familiar with the MCO in your state, we strongly encourage you to reach out and build a bridge with these very important organizations. Finally, the third panelist will provide you with a hands-on practical perspective from a provider's point of view, presenting strategies for keeping clients engaged in healthcare services. I'll briefly provide an overview of all 3 presenters' biographies and then hand over the floor to Donald Chamberlain, who will serve as a moderator for the rest of the webinar. Dr. Kara James, our first panelist, is the Director of the Office of Minority Health at the Centers for Medicare and Medicaid Services. Prior to joining the Office of Minority Health, Dr. James was the Director of the Disparities Policy Project and the Director of the Barbara Jordan Health Policy Scholars Program at the Henry J. Kaiser Family Foundation. Prior to joining the staff at Kaiser, she worked at Harvard University and the Picker Institute. Kara received her PhD in health policy and her AB in psychology from Harvard University. Our second panelist, Kim Nettleton, currently serves as a product director in the capabilities team of the community and state segment of United Healthcare, a managed care organization. Kim has been in a variety of roles with United, including health plan operations, health plan marketing, and Medicare regional director. Her current focus on the national capabilities team is around the impact of social determinants on healthcare. Kim earned a BA in speech, public relations, and has been involved in healthcare for more than 35 years on both the provider and the insurer sides of the business. Finally, our third presenter is Jessie Beebe. Jessie works as the Health Services Specialist for the Center for Housing and Health, a subsidiary agency of the AIDS Foundation of Chicago. For the past 2 years, Jessie has assisted over 200 permanent supportive housing residents and their housing case managers in navigating healthcare changes in Illinois. Specifically focused on Medicaid expansion and Medicaid managed care enrollment, Jessie has provided education and support to very low-income, chronically homeless, and medically vulnerable residents as they enroll in Medicaid, as well as choose a managed care health plan. Jessie is a licensed clinical social worker and has a bachelor's in social work from St. Louis University, as well as a master's of social work from University of Chicago. With that, I'd like to turn the floor over to Donald Chamberlain, our moderator. Thank you very much.
Thank you, Rula, and welcome everyone to this third webinar. I will be entertaining questions at the end of the 3 presenters, so as Stacy said, please feel free to type them in. And without any further ado, I'll turn the program over to Dr. James.
Thank you so much, and good afternoon to all of you, and good morning to those of you on the West Coast. I'm thrilled to be here today to talk to you about an important initiative that, as Rula mentioned, is critical in helping individuals who have coverage be able to understand it and get the care that they need. So if you go to the next slide. Over the past couple of years with open enrollment and the expansion of Medicaid and CHIP, we've seen millions of individuals obtain coverage through the marketplace or Medicaid, and even some of those who've aged into Medicare who were previously uninsured. And for many of them, this may be the first time or the first time in a long time that they've had coverage, and they may be unfamiliar with key insurance terms or how to navigate the system to get the care that they need. And as Rula mentioned, many of them may be using the emergency room for their source of care. So in effort to address some of these issues, we started from coverage to care to help educate consumers about their new coverage and connect them to primary care and preventive services that are right for them so that they can live a long and healthy life. Over the course of about a year and a half, we developed a number of resources. I'm going to go through two briefly in this conversation today. And we rely on existing networks such as yourself and other community partners to share these resources because, as we learned in our projects as we were developing these, you are the trusted resources in the community and the most effective in delivering the message and ensuring that consumers understand the information that's being shared with them. So we have really relied on existing networks to share these resources. Next slide. As you can see, our website is marketplace.cms.gov/C2C. I encourage you to all go there if you have not been there already. You'll find a number of resources that we've developed, an enrollment toolkit, a roadmap that we're going to go through, as well as some of the one-pagers, posters, and other sources of information. We also have a discussion guide, understanding that some of our community partners may not be familiar with the conversations of talking about health given the area of work that they have. So we have a guide to help go through that. And finally, because we know that everyone learns in different ways, we have a number of videos that are available that can be ordered as a DVD. And you can order or print your own copies. You can order the copies through our CMS clearinghouse. All resources are available for free and will be delivered to your door. Next slide. So in starting off and helping people connect to care and be able to use it, one of the first critical steps is making sure that they choose a plan that's right for them. And as we learned during open enrollment in the first go-round, many consumers weren't certain about the plans that they selected or the benefits that were available to them. So in response, we have developed an enrollment toolkit. It includes 5 sections that you see listed here. I'm only going to highlight 2 given our time today, but it includes important messages about why individuals should sign up for coverage. We still have work to do in getting millions of Americans enrolled. Given our success that we still have those who are uninsured, and helping to frame why it's important for them to sign up for coverage is what we talk about in that first section. We also then go through some important information that they should know before enrolling in their plan, some things to consider when they're choosing their plan, and what to do after they've completed their application. We also have a section for helping consumers with special circumstances, including individuals with disabilities, those with limited English proficiency, and individuals who may be immigrants or mixed status families. Next slide. So in the first section, we talk about what consumers should know when picking a plan. And throughout the enrollment toolkit, at the end of each section, you'll see a number of resources where you can learn more information about the topics that have been covered there. But as you can see in this section, we cover plan selections, premiums versus actual costs, review of provider networks, stressing the importance of making sure that consumers are looking for providers that are in network and understanding the financial implications associated with receiving care outside of network. And for those who may have current prescription medications, understanding their prescription drug coverage. And finally, dental and vision coverage, emphasizing that many plans don't offer that, and if that's something the consumer needs, they need to look for that as well. Next slide. In one of our other sections, after consumers have gone through that process of getting coverage, we talk about making sure that they confirm their coverage, pay their monthly premium if they have one, and that they do so repeatedly, so not just paying that first premium, but maintaining coverage, reviewing their plan materials to learn about the benefits. If they don't already have one, finding a regular provider that they can begin to engage with, and because of the tax implications, keeping their information current via the healthcare.gov website or their state-based marketplace. Again, there's some additional resources to help consumers in understanding how to confirm their coverage, or if they've been denied, how to appeal their determination. Next slide. The roadmap is where we really kind of begin once consumers have coverage. As we were working on this project, we like to sort of internally call it the "so you've got coverage, now what?" And for many consumers, when they think about the importance of having coverage, they think about it as something, protection for when they get sick. But they don't necessarily view it as a tool that can be useful for helping them stay well. And so step one really emphasizes the importance of putting your health first, talking about finding that provider to get regular preventive services, reminding consumers that a number of these preventive services are available at no cost sharing as a result of the Affordable Care Act. In step two, we talk about the importance of understanding your coverage. We go through key insurance terms, and we also talk about sort of, again, the in-network and out-of-network. Step three, particularly important for what Rula was talking about earlier, of know where to go for care. And in this step, we really emphasize the importance of utilizing primary care for most services rather than relying on the emergency department, and utilizing the emergency department only in the cases of life-threatening illnesses or injuries. Step four, we provide some steps on how to find a provider and make the appointment and be prepared for that visit in 5 and 6. And then, because we do want consumers to develop a relationship with their provider, we think about in step 7 whether this provider is right for you. And we emphasize some questions that consumers can think about in terms of whether or not the provider communicated with them in a way that they could understand, if they treated them with respect, and if they felt comfortable sharing information about their health situations in order to address their health issues. If the answer to those are not all yeses, we offer some tips on how to problem solve some of those challenges, but also empower consumers to know that if things are not working well for them, they do have a choice in switching their provider. And finally, in step 8, we talk about some of the next steps after enrollment. Next slide, please. So just briefly, step 1, we really emphasize, again, putting your health first, reminding consumers that staying healthy is important for them and their families, and encouraging them to make time for physical activity, healthy eating, relaxation, and sleep. And we know the importance that housing and safe housing has on individuals' health and their ability to go out and exercise, and even to get good sleep. We also encourage consumers to take an active role in their health and to learn about ways they can stay healthy and to share that information with friends and families. On the next slide, you'll see that we provide some additional resources for helping consumers learn about the preventive services that they may be eligible for. My Health Finder on healthfinder.gov is a tool where consumers can add their information about their age and their sex and find out which preventive services are recommended for them. You can also see that through Medicaid, Medicare, and healthcare.gov, the preventive services that are available to consumers getting coverage through those programs. Next slide. In step 2, again, as I mentioned, really helping consumers become familiar with key coverage terms such as premiums, co-payments, deductibles, and co-insurance, things that for many consumers who may have been used to receiving care in a community health center or on a sliding scale, they may not have had to deal with these issues before, and these may be new terms to them. Throughout the roadmap, you'll note that we have boxes called cost tips, where we really try to help consumers see some of the financial implications of the choices that they make in the care they receive. For example, having care out of network is more expensive typically than care received in network. Next slide. As I mentioned, we have some tools to help consumers throughout the roadmap. One of them is this insurance card example to help consumers become familiar with where key pieces of information are on their card, because this is something that they are asked for as they call to make an appointment or as they go in to receive care. Next slide. We also provide a couple of examples in our step 3. We have a table of knowing where to go for care. And again, as you see on the first slide, the first row of that table, we talk about some of the cost differences associated with going to primary care, where you have typically a smaller copay than if you go to the emergency department. and particularly how you can be at risk for additional costs if it is a non-life-threatening illness or injury. We also talk about wait times, where you can make an appointment for your primary care provider as opposed to waiting in the emergency department until you can be seen. Next slide. And then just to kind of close out a little bit more on step 8, we talk about those writing down a provider's instructions and healthy living tips, following up with appointments for filling prescriptions or additional follow-up visits that need to happen, and reviewing any documents or bills that consumers may receive, and calling the plan or the state Medicaid and CHIP program if they have questions about their coverage. Next slide. We have an example of an explanation of benefits that consumers may receive with regards to their care, emphasizing, as you can see here, that this is not a bill, but it doesn't mean that they won't receive one, but just to help them understand how their charges are accrued. Next slide. There's a lot more information that you can see in the roadmap. In terms of time, I'm not really going to go through that, but there are a number of additional terms covered in our glossary, as well as information where consumers can track their own health information as well as contact information for their provider and insurance plan. Next slide. We also have translated the roadmap into 7 additional languages. As you can see here, it's available in Spanish, Arabic, Haitian Creole, Russian, Chinese, Korean, and Vietnamese. And we selected these languages based on a number of factors, one being the calls that we receive to the Marketplace call center and downloads for materials on our Marketplace website. But also these languages happen to coincide with the top 10 languages that are spoken in the U.S. other than English at home, and the languages for which the highest proportion of the population has limited English proficiency. We're working to make additional resources available through Coverage to Care, the consumer tools, and finalizing those in other languages as well. Next slide. So as you can see, there are a variety of organizations that are using our resources. We have organizations that are working with the elderly in area agencies on aging, as well as our SHIP counselors. We have United Way and a number of different organizations, and I think that that really speaks to the importance of reaching consumers where they are. Many consumers may not have a health connection already, but helping them get connected to care is critically important to help them achieve a long and healthy life. Next slide. So as we think about where we are with regards to our 2 open enrollment periods that we've had and the work that we have ahead of us, the journey of 1,000 miles begins with a single step. We've gotten millions of Americans covered through the early periods, but we still have a ways to go. And to ultimately achieve the additional aims of the Affordable Care Act of improved population health and reduce costs, we really have to work to connect these individuals to the healthcare system to help them understand how to use their coverage to maximize their health. But I know that working together, we can ensure that all Americans have access to quality, affordable health coverage, and that disparities in health are eliminated. Next slide. Again, you can find all of our resources on our Marketplace page. If you have questions, either now or at the end of the call after we get off the phone, please feel free to reach out to us and let us know. And also, because this is an ongoing initiative, let us know how you're using it, the resources, and what else would be helpful as you're engaging with consumers that you work with. Thank you.
Great. Thank you so much, Dr. James. I myself have watched a couple of the YouTube videos. They're really succinct and helpful. And I have to say it's very impressive how accessible and flexible, customizable, and free they are. So thank you very much. I hope all the 800 people on the call are able to access these resources and make good use of them in their community. Most of all, I want to thank you for being so empowering to the consumers. That's a very core element of our approach as well. With that, I'll turn it over to Kim Nettleton. Kim?
Good afternoon. I appreciate the opportunity to be here and to see if I can help answer the question about why does a managed care organization care about housing. Next slide. So what I want to start to do is to talk about the fact that one of the biggest opportunities as a Medicaid managed care plan that is just beginning to explore the opportunity of working with homelessness services providers, housing providers, and permanent supportive housing providers is realizing that there is a huge opportunity for a great deal of education needed on both sides. For Medicaid managed care plans to understand the services and systems serving those who are needing housing and those providing housing services, to understand Medicaid and Medicaid managed care. So that conversation, getting to know each other, getting to understand how we work together is really important. And I think that really starts with just the primary understanding Medicaid and who the different players are and how we work together. Medicaid is a joint program between both the federal government and the state government. The federal government sets some core basic elements that they require be included in a Medicaid plan. State governments have an opportunity to request waivers or changes to those programs, whether it be the populations that they serve, geographies that they are working with, certain benefits that they want to define, whether they want to use a health plan like a Medicaid managed care program to administer the program. And as they identify those programmatic elements that they have, they go back to the federal government for approvals on those programs, and then they oftentimes will, through a competitive process typically, choose MCOs to help administer the programs that they have designed. The MCOs are very closely monitored, and expectations are really high that we not only can assist the states with reducing costs by helping members achieve care in the right settings, including preventative care, but that we can help states and members meet quality goals. Goals like managing their diabetes, increasing immunization rates, decreasing inappropriate use of emergency rooms, and increasing primary care use, and helping people live as independently as possible in the least restrictive setting. Next slide. So when states first started using the Medicaid managed care plans, we identified together really kind of a triple plan, and that was a need to help improve the quality of care, which included the experience that members would have when they received care, improve the health care utilization, which meant making sure that they received the right health care services in the right setting at the right time, and then improve the health outcomes, making sure that members, if they have a chronic illness, can manage that chronic illness, or if there's a way to avoid an illness, that they have access to the preventative screenings and tools that they need in order to prevent those illnesses. Next slide. Again, when states first started using Medicaid managed care plans to administrate Medicaid, it was primarily in a TANF population, most often pregnant women and children. And lately, more and more states have begun to ask MCOs to help with the most complex and vulnerable populations: people with disabilities, children with special health care needs, people with intellectual or developmental disabilities, or severe mental illness. And as Medicaid managed care plans began working with more complex populations, it became ever more evident that the social determinants of health were key drivers in helping people to live healthy lives in the least restrictive environment. And so now we are beginning to look for new providers, new community organizations to collaborate with, and new ways to assist members and to ensure that care can be coordinated and services can be provided. Housing stabilization is one of the most important elements to reducing health system costs and to helping members live healthy lives. Next slide. Study after study has proven it. Housing reduces costs, particularly for the most complex populations, persons with multiple chronic conditions, often complicated with behavioral or substance abuse concerns. Next slide. So what are some of the things that United Healthcare is attempting to do? One of the first things that we are working on is, first of all, to understand housing, homelessness services, and systems. And we're educating our staff internally at health plans and across the enterprise to understand how the systems work, who to work with, what the language is, and how to begin to collaborate. Second, as we embark on pilots or projects in states, we are attempting, through the involvement of a national person like myself, to document some of those best practices so we can share those across health plans to speed the learning curve for all of our folks. We are working in one of our studies is to contract and to work with the continuum of care program providers. We actually have established contracts with 2 of those providers in Texas. The goal of that, this program is built off of the money follows the person model, if any of you are familiar with that. It is a program, a federal program that was designed to help people who are living in nursing homes who want to come back out into the community to live. In this case, we have contracted with the continuum of care. They have shared their HMIS database with the health plan so that we could identify which of our members were chronically homeless. And we are contracting with them to help them to begin locating and engaging our members, assigning a housing case manager, assessing their housing needs, and facilitate getting them housing, as well as helping us to get them connected with us so that we could facilitate their health care. Next slide. So we got started on this because we have an obligation to do an annual assessment. And we had a number of members who the membership files that we received from the state, the addresses were either incomplete or incorrect. And no matter what we tried to do, we were unable to locate these members. Yet we could see that they were using services, primarily emergency room and ambulance services. And we really needed to find a way to find these members and see what we could do to help facilitate a better use of services and making sure that they were getting appropriate services. At the same time, as we began to explore what was going on with the continuum of care providers, and we were looking at their data and seeing the types of statistics and the health status that we were finding there, it became very clear that some of our unable to locate members were more than likely some of the members that they were serving. We've had done our first contract with the Houston-Harris County Coalition, and their first match that we have done with the health plan has identified over 3,000 members that are actively accessing homelessness services at this point. Right now, we're at the status of continuing to analyze both from the homelessness side the types of services that they are providing, and from our side the types of healthcare services that they are providing, so we can identify the most vulnerable members that we can both target to try to get housed. Next slide. So what are some of the early lessons learned? Because we're still very much in the beginning stages of this project. Relationship building is foundational. This was really a matter, it's been about 18 months of work, learning to speak each other's language. We have different business models. And it really took a long time for us to get comfortable with, why is a managed care organization interested? Why are we in the room? What are we talking about? What services do we bring to the table? And how does the coordinated access system work? And how can we be a part of that? And how can we collaborate? As a healthcare organization, data is key. And as we began to collect the data and identify our members, as we begin to look at utilization, we'll really have an opportunity to see what kinds of impacts that we can do. Ongoing communication is huge. It is really important to constantly continue with that education and that communication and to help explain how our systems work. Next slide. So one of the other pilots that we have working on, again, started with data. It started actually, United Health Group as a company for many years has done low-income tax credit projects where we have helped fund affordable housing. In the process of funding affordable housing, it was done from a completely different segment, and we didn't usually tie our Medicaid members to that affordable housing. The tax credit team would do the investment. They would get their tax credit. We would get a nice press release out of it, and that was usually kind of the end of it. What we did this time was we funded a project in Austin, Texas. We got to taking a look at that. We looked at the group, the developer that was doing this, and met them early on in the process. We identified the fact they had several permanent supportive housing providers, and we looked at their addresses for those sites and matched them against membership and realized that we had almost 100 members currently living in permanent supportive housing. Again, what we started off with was simply building a relationship. cross-educating each other on who does what and how we can work together, and beginning to figure out new ways that we can work together to not only serve our members, but to perhaps bring other services to their site to serve the residents that are in that community. Next slide. So the initial conversations was really all about defining who does what the roles are of each, where we overlap and where we have gaps, and how can we communicate to each other on a regular basis. We had a nurse that had been visiting members in those complexes for many years and had no idea that this was anything other than a regular apartment complex. Had no ideas there was a case manager at hand, no ideas that there were additional services that was available, that there were services that they could do. At the same time, the resident case manager had no idea. They told the story of spending 2 weeks trying to find a podiatrist for a member. And when we said that's our job, not only will we find the podiatrist, but we're going to arrange transportation, and it won't take us 2 weeks to do that. So really building those relationships and figuring out how we can work together and what we're going to do in the future. Next slide. Again, early lessons learned, simply starting with identifying where the supportive housing providers are, what those addresses are, and sharing that with health plans, letting them identify the volume, the outcomes, and what's going on with members in that site, facilitating that cross-education, having those open, honest questions, admitting to not being familiar with each other's programs, and building that relationship. Clarify terms. We use a lot of the same words, and we mean different things. I'm sorry. We look forward to continuing to work with providers. We encourage you in your states, if United Healthcare is one of the managed care plans, to reach out to us. We look forward to working with you. Thank you.
Thank you, Kim. That was really excellent. I want to say, at the end of your slides, of course, you had a bullet for becoming a Medicaid provider, and many people on the call, of course, are eager to sort that out in their states, and that's a big focus of this technical assistance. And I also just wanted to reflect back to you that for those of us on the homeless side, we love hearing people talk about the social determinants of health, the importance of data-driven decisions and commitments to good communications and long-lasting partnerships. And I'd say clearly United Healthcare, as described by you, has scored high on all of those points. So congratulations and kudos to you and your company. And now let's move to Chicago and hear from Jessie Beebe with a picture of on-the-ground implementation that she's experienced and helped lead over the past 2 years. Jessie?
Hi, thank you so much. It's great to be with everyone today. So I'm going to talk a little bit about my role in connecting housing providers and the clients they work with to the Medicaid managed care system. Next slide. So just to give a little bit background on the healthcare landscape in Illinois, we expanded Medicaid starting in January 2013, and then we had Medicaid managed care and care coordination began in January 2014 and continue through 2015 of this year. So this is really made for some rapid changes for Illinois, and there's really a tremendous learning curve for housing providers, social service agencies, medical providers, and then not to mention the clients that are being enrolled into these managed care plans. So there was a lot of education and support around Medicaid applications and the marketplace, but not so much on managed care enrollment and how to enroll in a plan and how to use your benefits, especially use them for primary care services and outpatient care. Next slide. So my role is as the health services specialist, and it's really a designated role to work with housing providers and their residents on enrollment into Medicaid managed care, as well as continuous education and support to help connect those residents to their managed care plan, to their care coordinator, and also help their housing case manager, who is oftentimes the person with the closest relationship to that client, to understand these changes and how to connect their client to these services. So that includes a number of agency and housing case manager trainings that I've done around the city, I meet regularly one-on-one with housing case managers to talk about these changes and how they can help their client access benefits. I do home visits with clients where I really learn about sort of the challenges they're facing and what works best as far as educating them about their managed care plan and care coordination. And then I also am able to accompany clients to doctor's appointments. And this is really helpful, especially for individuals that are disengaged from healthcare systems, that are nervous about kind of making that first appointment. It really helps to accompany those clients, get them sort of settled and into kind of a primary care home where they can then access those services on their own. Next slide. So some of the challenges we face here in Chicago and Illinois, many clients were auto-enrolled into managed care. So they didn't know that they were assigned to a plan. They didn't know they've been assigned to a primary care provider. So it takes a lot of outreach and a lot of one-on-one communication to help educate them about that. You know, we work with very vulnerable populations. A lot of them have no access to cell phones or very little access. They're transient. They're really difficult to outreach for managed care. So it really falls on the direct service providers, the housing providers, to educate the clients and connect them to the managed care entity and kind of facilitate that relationship, at least in the beginning stages. And then, as was mentioned, many clients have health insurance for the first time. So it's a lot of education around how to use a primary care provider, you know, why outpatient care is important, and continuing to help people learn this new behavior, which for many people is very important. And then there are some additional complications for people living with HIV and AIDS. You know, if they're assigned a provider, we need to make sure that that person knows how to treat HIV. We've had some issues here in Chicago with medication coverage, so that's just sort of a special population that requires even more attention and education. Next slide. So some of the best practices I've found is really that consistent and continuous education and support. So, and I talk about it really as kind of changing a culture. So changing that culture from, you know, I don't seek care until I'm very, very sick, to, you know, I have a primary care provider that I have a relationship with that gets to know me, and that I can actually prevent illnesses and diseases and those emergent situations. So there, you know, there's really a lot of different resources out there. So I think focusing on the way those resources are delivered to clients. So I found that in the context of a relationship they have with a housing case manager, with myself, or with other direct service providers, that relationship is really important, and working with that person one-on-one to deliver that, deliver those messages. And then also, as I mentioned, attending doctor's appointments has been really helpful. I've developed some healthcare materials for housing case managers that are kind of Chicago and Illinois specific, but they're basically just very simple, straightforward guides on how to help clients access care, you know, a checklist that direct service providers can go through to make sure, is my client connected to their managed care system? Is my client accessing primary care services? If not, what are the barriers and challenges, and how can we work to address those challenges? How to help case managers identify where their client is enrolled, who their primary care provider is. And then one project we've developed is we have magnets, and we give them out to clients in our housing program to put on their refrigerator with information about their managed care entity. What are the important numbers to call? You know, how can they access transportation? How do they get in touch with their care coordinator? And we found that to be pretty successful with people. Next slide. So in terms of best practices for clients, I think that using concrete, specific, and really relevant examples to their life on how managed care will impact and improve their health, really focusing on their needs. Some people, for them, their health is very important. Other people, their health is not important. So it's really finding that goal or that need that the person values, and trying to connect that to having improved health, and being connected to managed care, and how those benefits will help you to improve your health. You know, really focusing on motivating clients to learn about and connect to their managed care plans, you know, connecting them again to those goals that they have, you know, providing resources within the context of that relationship for them to refer to and to use. And then I always stress to the case managers I work with, you know, try to connect to the managed care plan together at first. You know, sit with the client during your home visit, connect to the managed care plan, access the care coordinator, do it together, and that's really going to pay off in the long run when the client, you know, is able to access the managed care plan on their own. Next slide. So I found that visuals really are helpful when talking to clients about what managed care is. A lot of the people I work with are still learning about, what does this mean for me and how does this work? I talk about, I use the visual on the left to refer to the healthcare system sort of pre-managed care, and that really looks like, the client having to interact with all these different providers, having to be the person that holds that medical information and tries to communicate across the different people that are treating them. And then the visual on the right is really what managed care looks like, what care coordination looks like, and it's really the client connected to a team of people that are helping to coordinate their care and are helping those providers to communicate with each other to improve individual health. So I found that this really is helpful when talking to clients and educating them about managed care. They really connect to this visual and coming up with specific examples relevant to their life. That's been really helpful as opposed to just kind of talking about them or delivering, pages of messages. Next. So best practices for case managers. I really encourage them to connect with care coordinators and develop relationships with care coordinators. The case managers, are really sort of the catch-all for all of the different needs and issues that clients have. And, really encouraging them to reach out to these care coordinators that are, their jobs are to connect clients to providers, to help them get transportation to appointments. That's something that can be sort of taken off the plate of a case manager and kind of incentivizes them a little bit. But, case managers are really the experts when it comes to understanding what the client's needs are and challenges. So again, having that relationship with care coordinators, being able to share, this is what my client's experience is, these are their needs, these are their challenges, is really beneficial to both the managed care and to the client. My role as a health services specialist has been great, just to have one person focused on how to help clients connect to managed care, how to help case managers and housing providers and other social service agencies understand these changes and what it means for them. And then really just encouraging direct service providers to integrate managed care and care coordination dialogue into their regular visits. Really talk about this with clients. It needs to be a message that's delivered on multiple fronts using different mediums and really consistent and continuous. Next slide. So one exciting thing in Chicago and my work has really helped contribute to is we've developed what we call the Better Health Through Housing Collaborative, and we're really trying to partner with managed care entities, partner with hospitals, and promote housing and support services as a healthcare intervention to improve health outcomes and reduce costs. So we have a couple pilots in the works with different hospitals and managed care entities, and the goal is really to strengthen the connection between the housing case managers and the care coordinators within those pilots. And really demonstrate the value of supportive housing and the role that we can play in helping our clients connect to managed care, to care coordination, and really promote health and improve overall health and really reduce healthcare costs. And I believe that's it. Thank you.
Excellent. Thank you so much, Jessie. I'm always inspired by the work that your collaborative efforts in Chicago has manifested. And in particular, again, hearing about patient-centered approaches and the idea that it's the one-on-one connections, the reminders, the visuals, the integration, the multiple methods, the multiple levels, the ongoing education and support that make the difference. And I think what's fantastic about both the models that all the models actually, is that they're designed around that it's not something that the staff member themselves has to say, oh, now I've got to do this. It's part of the approach. And I think it's shown that that's what's successful. So at this point, we have a few minutes left for questions. Let me remind people on the call that if you'd like to ask a question, please type it in. We will respond. We have the capacity only to respond to written questions. I have 3 to answer right away, and I think I'll ask you to start, Jessie, because I think they both relate first to you, and then Cam, I think you'll want to chime in after that. So the first one is a general question. When speaking about a housing provider, are you referring to agencies or landlords?
When I speak about housing providers, I'm referring to agencies. So those agencies have relationships with landlords and work with landlords, but my primary focus is on the supportive housing agencies. Great, thank you. And David, if that doesn't answer your question, please feel free to type a follow-up.
The next question from Lloyd asks, how do you handle client privacy and HIPAA requirements?
So when our case managers reach out to care coordinators or vice versa, there's definitely a release of information that needs to be signed before there can be any communication. And I believe the managed care plans are very, we encourage that, and we make sure that our case managers know that that needs to be in place. But I believe the managed care is also very much aware that there needs to be a release signed before that communication can begin.
Kim, do you want to add anything to that?
No, I would agree. Again, it's a matter of asking the member or the resident for permission to reach out and having that release signed, or having them be with you if you're contacting the care coordinator from the managed care company.
And Dr. James, any thoughts from CMS on this topic?
I think that I don't have much more to add. I think that, it's a very important issue, and we're continuing to also work on this and protecting people's information as well.
Okay, great, thank you. So here's a specific question, which I think will raise eyebrows for many. It's from Victoria, and she writes, Medicaid keeps switching my youth Medicaid to inactive status, stating that they are incarcerated when they are not. Any suggestions on how to get them to stop doing that? I cannot get a hold of anyone who will actually call me back.
So I can start. I think if I don't know what state they're in, but if they want to email us, we have caseworkers within our regional office who work with each of the state Medicaid programs, and we can help them to put someone in touch to help them navigate this space.
Thank you. Kim,
sorry, and this is Kara. I was going to say, if you want to, the email address again, since I see the slide is down, you can email us at coverage2care@cms.hhs.gov.
Great, thank you. Kim or Jesse, do you want to add about that question about helping correct status errors in your states or your programs?
I don't have anything to add to that.
Yeah, the only thing I can add is usually each state has ombudsmen that can help, or health plans often have member advocates that can work with state enrollment providers that can help the process of navigating through. So if you're working with a Medicaid managed care plan, you might reach out to see if there's a member advocate that can assist you, or to see if there's an ombudsman in the state that can assist also.
Great, excellent advice. And I think because of time, this will be our last question. I'd like to ask you to answer it first, Kim. This is from Ken, who asked, please distinguish between case management and care coordination. In different models, those terms are occasionally used interchangeably.
So I actually have found that those terms have a variety of different meanings, and what we have begun to do in each meeting that we have gone into, whatever term somebody uses, whether it's case management, care coordination, service coordination, we've asked folks to stop and to give their definition of what that means to them, and then to let the other organization explain what it may mean in their organization, because we really find that making sure that we are defining those and that we are clarifying those terms, there's not consistency. There's not consistency from organization to organization, from state to state, or from the housing side of it to the healthcare side of it. So I think the key is every time we use a term, it's sitting down and saying, what does this term mean to you? And clarifying what each party means and coming up with an agreement on how you're going to be using the terms.
Thank you. And then just a quick 1-second follow-up. Beth writes to say, how can we determine if our area has any care coordinators?
So if you look on your state website for your Medicaid health plan or Medicaid organizations, they will have information on the type of Medicaid programs that are there. and often they will outline the key benefits or programs that are available to the clients. And if there's care coordination or service coordination as a part of the health plan or the health benefit, that's often outlined in it. The other thing is, if you are working with a client or with a health plan, is to simply ask the question, what types of services, what types of coordination or navigation are available to the clients that you serve? I mean, ask the question.
Great. Thank you, Kim, Jesse, and Dr. James, in your responses, and everyone for asking their questions. And now I'll turn it over back to Rula for closing.
Thank you, Donald. And I'd like to echo your statement as well and express my deep appreciation to Dr. James, Kim Nettleton, and Jesse Beebe for your time and expertise today. We've had hundreds of people tune into this webinar, and I hope that you will continue to prioritize your efforts on promoting effective utilization of the healthcare system, because on a number of levels it will improve the experience that people who are homeless are having. It will help stabilize their living situation, and it will cut down costs on the healthcare side. It's just a win-win on every side, and each one of you are very critical players in this process of improving care and helping to end homelessness. Please contact us. Our contact information is listed here on this slide. If you have specific questions, for example, if you'd like to request the specific tools that Jessie Beebe mentioned during her presentation, please reach out to her. And if you have questions about specific Medicaid-related issues, please reach out to Dr. James using the email address here. On the next slide, I just want to point out a few more additional resources for you. We will be posting this webinar. It has been recorded, and it will be posted on the very first link that you see listed here at the top of this slide. So you can go back to the resources and reference all of the PowerPoint presentations as well as this discussion. If you know people that would like to join our mailing list and participate in future webinars, please reference the third bullet point and pass along this information. Others can join the mailing list and participate in future webinars. We have 2 more that are coming up in the coming weeks and months that will again focus on housing and healthcare integration. And this is going to be a very important topic as we move forward, effective utilization of the healthcare system for people who are experiencing homelessness. There is also the link at the bottom of this slide to the From Coverage to Care initiative and all those wonderful resources that Dr. James referenced. And on the next slide, we'll just wrap up. If you have any general questions about the H² Technical Assistance Initiative, which is broader than this series of webinars, we are also conducting meetings across the country to convene homeless assistance providers along with healthcare providers to develop action plans to improve integration between the 2 systems. Among other strategies. If you have questions about the H² initiative more broadly, please feel free to reach out to me at this email address listed here. Otherwise, I'd just like to thank you all for your wonderful service and your commitment to serving people who are homeless and at risk of homeless. And thank you again very much for your time today. Bye-bye.